Now.
Good afternoon. So I'm Silvana Markovska Simoska, and I will talk today about improving the accuracy of ADHD diagnosis in adults using neurophysiological biomarkers. So we know that the core symptoms of ADHD are inattention, hyperactivity, and impulsivity. And the core symptoms of ADHD in adults are more or less the same, with difficulty of paying attention, often getting distracted, disorganization, procrastination, poor time management, and problems with planning. Estimated prevalence of current adult ADHD is 4.4 to 5% in the population worldwide. ADHD is often firstly diagnosed in childhood, but also it can persist into adulthood. And in the adults, ADHD can be presented a little bit differently. It means that maybe hyperactivity will be decreased, but problems with attention will still persist. Also, sometimes many ADHD symptoms overlap with another mental health conditions like anxiety, depression, or personality disorder. So differentiating these symptoms from ADHD symptoms could be very challenging. Adults with ADHD often have co-occurring mental health issues such as substance abuse, mood disorders, or learning disabilities. And the presence of these comorbidities can obscure the underlying ADHD symptoms and could complicate the diagnostic processes. Patients may have difficulty distinguishing ADHD-related issues from symptoms of other disorders. The assessment of ADHD usually is heavily relies on self-reported symptoms, but always we must have in mind that adults with ADHD may underreport or minimize their symptoms due to lack of awareness, denial, or social desirability bias, but also they could have memory lapses or distortions about their childhood experiences with ADHD symptoms. ADHD symptoms can manifest differently in various settings, for example, at work, home, or social situations. And we must also gather information from third-party sources like family members or teachers that will give us more information about the individual functioning. However, also access to reliable informants may be limited, especially in the adults, and their reports also could be very subjective. Because there is still no universal consensus of the specific diagnostic criteria for adult ADHD, usually the clinicians use rating scales, interviews, and questionnaires, which are all of these are actually subjective measures. Now the science is going in that direction that we need the biomarkers, especially for diagnosis of adult ADHD. Why we need these biomarkers? Because all of these problems that I already mentioned, and actually the subjective assessment should be supplemented with objective performance-based tests and physiological measures that will enhance the accuracy of ADHD diagnosis in ADHD adults. So I have here now the question. For example, if do you want to be in situation A? You go to the doctor and complain of knee pain. So would you like that further 3 to 5 discussion about your knee condition will be arranged, and that will be everything about the diagnosis and treatment? Or do you want to be in the situation B, to go to the doctor and complain of knee pain, but the doctor will give you pills and creams, he will push it in your hand, without any further examination? Or do you want to go at the doctor? The doctor will be examined the knee in detail. And for example, you will receive a diagnosis, and treatment will be based on actually what the diagnostic methods he will use. So I actually decided 22 years ago for exact diagnosis and treatment, especially in mental disorders, because these methods are giving us precise information on our brain function. Of course, this complements the previous conventional diagnostic which we always do. How we measure the brain function? Actually, we use the EEG or quantitative EEG electroencephalogram, and we record the brain activity in eyes open, eyes closed condition for 5 minutes each. And then we give go, no-go task, visual continuous performance task for the duration of 22 minutes, in which we have visual provocation through images and auditory provocation through sounds. We have 4 conditions. Animal, that is go condition, then animal, plant, no-go condition, and then we have plant as ignore condition, and plant, human, sound, also as ignore condition. Actually, it looked like just a short review of this task. So animal, then press or go condition, plant, no-go condition, animal, go, animal, plant, no-go condition, animal, go condition, or pressing the button, animal, plant, no-go, withholding yes. So this task is actually lasting about 22 minutes, and you will see later what results we are gathering from it. So we use 3 independent dimensions, or we use 3 independent windows to look into the brain activity, and that is evoked or event-related potentials, the spectra, EEG spectra, and behavioral parameters like reaction time, variation of reaction time, omission and commission errors. So all of these are independent functional neuromarkers for assessing the brain activity. So now I will represent how actually we use objective measure or objective diagnosis of ADHD in adult. So we use report generator. That is the report that contains everything that is currently needed for diagnostic insight and help us for development of personalized treatment of ADHD adults. This report generator is actually made by Professor Andreas Müller from BrainArc in Switzerland. This report is made up of 3 parts. First part is neuropsychological, then we have neurophysiological part that is subdivided in 2 parts, EEG spectra and event-related potentials, and at the end we have actually conclusion. It is a really big report on 70 pages. So the first part, as I already said, is made of results of the questionnaire that the client is answering. There are many questions that he's answering about his behavior. And one of these is questionnaire, Amen questionnaire, that examines relation between answers to the question of the everyday functioning and connection of this functioning with different brain structures. On the left side here, you can see how the result or graph of the answers of the ADHD adult look like. And on the right side is actually the results of a patient that comes with complaints like ADHD, but actually it is a depression, not ADHD, not real ADHD. So here we could see a huge difference. And especially, for example, for ADHD, we could see that the main brain structures that are affected are cingulate cortex and prefrontal cortex. And here we cannot make some distinguishing differences between the brain structures. Then we have another test, Van Dusen, also depicting which cortical region is affected by client's pattern of responses. Here is also the function of prefrontal cortex are the mostly affected, like or executive functions. Then we have ADHD questionnaire, where we are depicting if it is inattentive, hyperactive, or combined type of ADHD, if also the client has emotion regulation comorbidity or not. Then we have SCL, a subjective checklist in which, for example, also here we could see the psychological problem in the last week of the patient, and on the left side, which is ADHD, we could differentiate that ADHD scale and anxiety are the most the scales with the highest percentile ranks of the distress. On the right side, again, are the result of another patient that also come as complaining with ADHD symptom, but actually he was not a real ADHD. Then we have another test for hypomania, and that is more or less everything for the first part of the report about the neuropsychological measures. Then we are coming to the neurophysiological measures, and we are starting with analyzing the task performance. Here we analyze omission, commission errors, reaction time, and variation of reaction time. And as we could see, the omission errors are actually index of inattention. Commission errors are index of hyperactivity or impulsivity. So these are significant in this patient. Reaction time is normal when it is compared with database, but variation of reaction time is also increased. That means that it is significantly impaired in comparing to control adults. Here we could see actually how it looked like on the graph. It is better represented. So on the left side is actually the task performance of ADHD adult with high reaction time variability, with many mistakes. And on the right side is the result of non-ADHD adult. Then we also analyze the reaction time in milliseconds, and we are seeing the distribution of reaction times and also distribution of errors over time. Actually, in this case, in this example, we have more mistakes at the end of the task when actually the patient is starting to be more inattentive and impatient. Then we analyze the spectral data. So these are the spectral data on the left side of the EEG spectra. So everything that is red is theta brain activity, yellow is alpha brain activity. And on the right side, we have comparison of EEG spectra of the patient with the EEG of database or normotypical adults on his age. And here we also could see the Z-scores where, for example, the certain brain activity is increased or decreased. So in this case, we have increased theta activity frontocentral and also increased alpha more or less everywhere over the cortex. These are also the brain maps that are analyzed for the patient for absolute and relative power spectra. And this is done for all three recording conditions: eyes open, eyes closed, and for VCPT or for the task. Then we could, with using Loretta, low resolution brain electromagnetic tomography, we could see which brain region or which Brodmann area is impaired and which Brodmann area is generator for some abnormal activity in the brain. Then we could calculate the theta beta ratio, and this theta beta ratio also has a very it is a parameter, index parameter for inattention, especially in children, but in this case this is also found in adult. We could also calculate arousal. Arousal represents actually the state of the vegetative nervous system. And here in this case, we are seeing the hyperarousal in this patient, in or more or less in all three states: eyes open, eyes closed, and during the task. We could also analyze central sensory index, vigilance, which is the state of increase and permanent readiness to react, coherence, that is actually a parameter which tells us which brain region is connected with which brain region, or relationship between various structures in the cortex. In ADHD, more or less, they have less coherence than the normotypical adults. And at the end, we have analysis of evoked or event-related potentials, cognitive event-related potentials like P3B engagement component, P3A inhibition or suppression component, and P4 monitoring cingulate cortex, or as we called it, self-monitoring component. So these event-related potentials are telling us how the information processing is going on in different brain regions. And usually, especially these three event-related potentials are lower than in ADHD than in normotypical adults. Here, for example, we have lower P3B component and lower P4 monitoring component. At the end, so we make calculation from all of these measures, all of these parameters, and the report generator actually is calculating the indexes and is giving us percentages of how much probability is of ADHD to a patient or to a client. So in this client, we have ADHD probability of 76%, and if we add the behavioral data, it will be 81%. According to this, after that, we can personalize the treatment, like giving appropriate medications, or we could make a protocol for neurofeedback. So as a conclusion, we could say that maybe the biomarkers are maybe the future direction of ADHD diagnosis and treatment. We could say that subjective assessments are essential, but they should be combined with another evidence-based approaches like the biomarker approach. And also, we must have in mind that ADHD in many countries is still often perceived as childhood disorder. So this is leading some adults to resist or to deny the possibility that they have ADHD. So we should just raise the awareness about the existence of ADHD in adults. Before finishing, I just want to say what are actually our ideas for the how the in the future, how the working space of the biologically oriented psychiatrist should be. So every psychiatrist should have EEG, and for example, the psychiatrist should make EEG recording of every patient to process this recording, and according to the analysis, to the gathered data of the analysis, then the psychiatrist could choose which therapy or treatment to choose. In this case, for example, to be neurofeedback therapy, transcranial direct current stimulation, CBT, cognitive behavior therapy using drugs, electroconvulsive, deep brain stimulation, or transcranial magnetic stimulation. So this is how we imagine that probably the future of psychiatry should look like. For the end, like take-home message, I will say that for the diagnosis of ADHD, autism, and all mental disorder, further objectification is urgently needed. This will provide security and for professionals and for patients. The treatment based on this will lead to faster and goal-oriented changes. And of course, that this procedure will save cost and time. because idle time will be largely avoided. At the end, I want to thank to ADHD Hellas and especially to Christina as a secretary of ADHD Europe for inviting me to present at this conference. And I wish you a very fruitful and successful conference, and I hope we will manage to collaborate in the future. And I also want to thank to Professor Andreas Miller from Brain Assessment Research Care in Switzerland for supervising my work and for giving me all this opportunity to be better in my practice with my patients. Thank you very much.